today we will be talking about Recommendation 2, which is to expand opportunities for nurses to lead and diffuse collaborative improvement efforts. This webinar is sponsored by the INQRI program, and I'm pleased to introduce you to Mark Pauley, INQRI's co-director.
Thanks, Heather. I'm delighted to be able to kick this off. Of course, all of the recommendations on the future of nursing are important, but this one's one of my favorites, and I'm really looking forward to hear what our two faculty have to say today and what our responses will be. Let me mention and tell you a little bit about each of them and then turn it over to them. Dr. Linda Flynn is a professor in the College of Nursing at Rutgers University. Her funded program of outcomes research is focused on the effects of nursing systems, such as nurse staffing levels, the practice environment, and nurse manager leadership on patient care and patient outcome across practice settings. Within the hospital setting, she recently quantified the relationships among the practice environment, nurses' safety practices, and the frequency of non-intercepted medication errors on 82 medical surgical units. She has developed and implemented a nurse manager development program, NMAP, aimed at improving patient safety and reducing adverse events. She's been the recipient of a number of awards, and she's the co-editor of the textbook, Nursing Policy Research, Turning Evidence-Based Research into Health Policy. Suzanne Gordon, our other faculty member, is an award-winning journalist and author who writes about healthcare delivery and healthcare systems. Her most recent, among 15 books, is one entitled First Do No Harm, Confronting Inconvenient Problems in Patient Safety. Her books on healthcare have been published by the Culture and Politics of Healthcare Work series at Cornell University Press, which she edits. She's been a radio commentator for CBS Radio and NPR's Marketplace program. Her articles have appeared in a number of periodicals. She's also a visiting professor at the University of Maryland School of Nursing and is working on a new book on how to create and sustain team intelligence in healthcare. So let me turn things over to Linda and Suzanne. Take it away.
Okay, thank you so much, Dr. Pauley. It's a pleasure to be with everybody today. I'm sure that all of you by now are aware of the IOM report, The Future of Nursing, Leading Change and Advancing Health. And recommendation number 2 really is looking at expanding the opportunity for nurses to lead and diffuse collaborative improvement efforts. But if you just look at the first part of that recommendation, expand opportunities for nurses to lead, we had to ask ourselves the question, based on prior research and surveys of nurses, do nurses, especially those in frontline manager positions, have the skills to lead? Do they know how to lead? Have we as nurse educators and researchers and stakeholders in the field done our job in preparing nurses to lead? And so that is what really brought us to this project. I'm going to now, that was sort of a brief introduction of our thinking on this, and I'm going to introduce you to Suzanne Gordon, who is, as Dr. Pauley said, the very well-known journalist and patient safety advocate, to get her perspectives on currently what she sees as the gaps in nurses being able to advance their leadership opportunities. So, Suzanne?
Thank you. I had the privilege to work with Linda Flynn on the NMAP project and to interview many nurse managers over the course of my 26 years working with nurses, and primarily because of my interest in patient safety. And I think that one of the main questions that arises when one talks about leadership is really what does it mean to be a leader, and what are leaders supposed to do? And for the purposes of our project and in my work in patient safety, it's really important to have what I call team intelligence, which is the active capacity of individual members of a team to learn, teach, communicate, reason, and think together, irrespective of position in any hierarchy in the service of realizing shared goals and mission. And we know from patient safety work that many of the vast majority of medical errors and injuries and problems in patient safety, as well as problems in recruitment and retention of staff and job satisfaction, have to do with lack of teamwork, lack of communication. And in order to have a team, you have to have a leader. But what does it mean to be a leader? Is a leader someone who just tells people to jump and they say how high? Or is a leader someone who helps people learn together and think together? Is a leader someone who gives orders and who views other people as helping them do their job? Or is a leader someone who has team intelligence and recognizing that their job is to help everybody else as a leader? Their job as a leader is to help everybody else do his or her job efficiently and effectively. And I think what I found and what when we began with this project was we all found that nurse managers really had no training in leadership defined as we define it, and that people were really felt very much the lack of this kind of training, and I use the term training because deliberately because it is a training. You have to be trained to lead a team and to be a member of a team. People didn't know how to bring people together who were in conflict. They didn't know how to listen. They didn't know how to solicit input, and they were really, in a sense, felt amazingly disempowered in this regard. We had discussions with managers who felt that if there was a conflict between members of their workforce, that they had absolutely no skill to bring those people together to facilitate conversations that would resolve those conflicts. They were often not aware of how systems issues affected a conflict. And, for example, there was an aide and an RN who were battling about getting a blood pressure cuff because one was always hoarding the blood pressure cuff, and the manager was not involved in second-order system thinking, and so the real issue here was not necessarily the personalities of the people in the conflict, but how come there weren't enough blood pressure cuffs on the unit. And so our work really targeted this, this work that we did really reinforced, I think, some of the reasons why, as Linda's work has pointed up, and as my work has also highlighted, so many staff nurses feel unsupported by nurse managers, and which is a very sad thing. And I think that what we learned in this set of workshops and what we tried to remedy was giving that this lack of support is often obviously because of conflicting imperatives, but also because nurse managers don't have the skills to be supportive, and which is why we were very concerned about moving beyond emotional intelligence to team intelligence, because emotional intelligence just focuses on a dyad, whereas team intelligence focuses on the system, and we certainly need both, and we discovered that they were lacking, and I think this creates very, very serious problems for patient safety. Not only
Suzanne?
Yes.
Now, I think that's a wonderful segue to the next slide, if I may. Okay. Thank
Please.
you. So, as Suzanne said, our focus was really the frontline nurse managers, because there has been several studies, basically a body of studies that have shown that competent frontline nurse managers enhance patient safety. But we also know, as Suzanne just said, that few frontline nurse managers, now these are entry-level nurse manager positions, few of them receive any kind of formal management or leadership training. And in one of my prior studies, I surveyed over 20,000 RNs in the state of New Jersey. Almost 10,000 of them were staff nurses. And of those 10,000 or so staff nurses, 43% reported that their manager, their frontline nurse manager, was not a competent manager. And 47% reported that they never received any kind of acknowledgement or recognition for a job well done when they did feel that they had done a good job. And as managers, we all know that that's just absolutely key to developing a trust relationship and to developing a team. So we designed a nurse manager development program, and it was indeed funded by the Robert Wood Johnson Foundation, grant number 68224, as part of the INQRI, Interdisciplinary Nursing Quality Research Initiative. And I'd like to introduce the entire team because this was a translation study. The team was fairly large. Joel Cantor and I were the principal investigators. Suzanne Gordon was the coordinator of the series of manager development workshops. Kate McFall is an expert in violence in the workplace, especially among healthcare workers, and she was a key participant in the workshops. Dr. Terry Lindgren and Dr. Jerry Dixon were our qualitative researchers because this was a mixed methods evaluation. Dr. Eric DeLeo was a quantitative statistician who helped us with the quantitative side. And Allison Creary was our very important project manager. So many thanks to all of them. So what was the NMAP program? Well, NMAP stands for Nurse Manager in Action Program, and it was a series of 5 full-day frontline manager development workshops, once per month for 5 months. And we staged it this way because the workshops were extremely interactive. And at the end of each full-day workshop, the managers were sent home with skills to implement, with homework, so to speak, and then they would come back the next month and report about their progress or their challenges in implementing their new skills. We based it around 5 key concepts, starting with crew resource management and team building. And we were very fortunate to have a colleague of Suzanne Gordon's, Pat Mendenhall, who is not only a commercial airline pilot, but he is also, he conducts crew resource management training for the airlines, both in the United States and internationally. And so he was absolutely exquisite in pointing out the key principles of CRM and how safety in the airline industry, the same principles would translate into the healthcare system. And so that was a marvelous kickoff for our workshop series. The next series was really focused on transformational leadership. And we were pleased to have Karen Kowalski from Denver, who is an expert in transformational leadership, lead that workshop. For our conflict management, we had Dr. Bridget Regan, who is an attorney and a conflict management expert from the University of California, Berkeley, who was extremely helpful in giving the attendees some very practical tools. We did a lot of role-playing where the attendees implemented those tools, those communication tools, in resolving conflict. Our fourth was on team communication, and Suzanne Gordon led this particular workshop, and we had a variety of interactive kinds of learning experiences, including a play that Suzanne helped to write that highlights the communication challenges and also the communication successes between nurses and physicians and between nurse managers and their staff. And then our last module focused on enhancing patient safety, where we just brought everything together and focused on now how do we apply this to improve safety on the individual units. And also during that session had a train the trainer, because part of our plan was for these attendees to take their newfound skills and content back to their hospital and share them with other nurse managers on their in their facility. So who were these people that attended the workshops? There were 36 frontline managers of medical surgical units from 17 New Jersey hospitals. I also invited faculty from 3 New Jersey universities to attend, and there were probably about 5 or 6 of those. I was focusing predominantly on those faculty who teach nursing leadership courses in their curriculum, so that they would have the benefit of hearing these national experts that we brought from all regions of the country to talk about enhancing leadership skills. The evaluation plan really involved 31 intervention units from which these 36 frontline managers were recruited, and also 25 comparison units in their hospitals where the nurse managers did not participate. So there were a total of 56 med-surg units altogether from 17 New Jersey acute care hospitals. And then in those hospitals and on those units, we surveyed staff nurses pre-workshop beginning and post, about 6 months post-workshop, to get their ratings about their work environment, their manager skills, etc. So a picture is sometimes worth 1,000 words, and here is Karen Kowalski leading one of the workshops on transformational leadership. This is Bridget Reagan from Berkeley talking about conflict management and how we can use some very practical tools to reduce conflict on our units. This is Suzanne and Bridget, and they are leading an interactive session, some role-playing that is going on between them and then between participants. And we did implement some of the principles of translation science, realizing how important branding and packaging was to engage the participants. And so we branded just about everything that they took home with them with the NMAP logo. They received coffee cups, a tote bag, a lot of materials, 2 workbooks, log books, etc., with the NMAP logos. We also gave them textbooks. At the beginning of the sessions, they completed some extensive leadership assessment tools, emotional intelligence assessment tools, so that they could see where their own personal strengths and weaknesses were in these areas. We gave them some books by Suzanne Gordon that really talked about being an advocate on your units for patient safety, et cetera, as well as a copy of the play. So how do we know if we made any impact? What was our evaluation design? Well, as I said, it was mixed methods. We did qualitative interviews with 10 of the 36 participating frontline managers, 2 series of interviews, one early in the workshop series, and then again we interviewed them individually 6 months after the workshop series. And these were qualitative interviews conducted by our 2 qualitative researchers, where we asked very probing questions and got their reaction to the program and how they could or could not implement some of what they learned on their units to improve teamwork and hopefully improve patient safety. As I said, we also conducted RN surveys on all 56 units pre-workshop and then about 3 or 4 months post-workshop at the conclusion of the series. And then we compared patient outcomes on the comparison and on the intervention units for 6 months post-workshop series to see if there were any differences in outcomes, to see if we had any impact whatsoever on patient safety in the area of patient falls and medication errors per 1,000 patient days. So what did we find qualitatively? And our team talked from the very beginning as we were conceptualizing this study that we really were perhaps most interested, in a sense, in the qualitative findings because we thought that they would indeed be richer than the qualitative findings. And what our qualitative researchers found were a series of reoccurring themes that they categorized under the large category of process, outputs, and outcomes. And I'll talk about each one of these quickly in turn. But the managers, as they were interviewed 6 months after the workshop series ended, really talked about the basics of enhancing teamwork on their unit started with their skills in enhanced communication, the skills that they learned in the workshop, that it all really starts with that. And their feeling, what they reported and what they described was that then, in turn, the foundation of enhanced communication was really showing how you would value and acknowledge your staff, and then start engaging your staff in projects and in gaining their input. They then talked about how this then leads into better conflict management and how they use the skills they learned to take their teamwork to the next level and strengthen their relationships with the staff. Thirdly, they thought that the next really phase, if you will, in developing their team was in encouraging innovation and really engaging their team members in decision making. And then lastly, they felt that the final outcome was that they felt that patient safety was improved, and that importantly, they began to learn and understand the difference between management and true leadership, which was really our goal with this. So let me talk a little bit about what they said with enhanced communication skills, and I'll just give you just a flavor of what some of the attendees, the frontline nurse managers, said in the interviews. The communication skills that we were able to learn in the workshops have really been probably the most useful tool. You know now how to have those hard conversations. Another manager said, a lot of times we look at our staff and we dictate to them, but don't fully explain well, and we don't make sure everybody is on board. So I think this program has really helped me to look at each one of my staff members as an integral part of the process. They also talked very clearly, in fact, 90% of all of our interviews, both pre and post, or early and post workshops, talked about the value of acknowledging the staff. That was one of the points that they really took away and were able to implement. It was one of the first skills they were able to implement, and they really reported that it had a dramatic effect. As one nurse manager says, I integrated the thank you, showing your gratitude to staff. I really have been focused on that so that the staff feel appreciated, showing public gratitude. I have integrated that. Another one said, one of the things I do now, at least more consistently than before, is to actually praise people and thank them for a job well done, not only in public, but also send them little notes and cards, or I'll post something. And I know this seems to us like such a little thing, like duh, didn't they know this? Didn't they think about it? But they just weren't focused on it. As my prior survey showed, 47% of 10,000 staff nurses in New Jersey said they were never acknowledged for a job well done. And so that was indeed a take-home point that I think our manager attendees were able to really implement. They also talked about the importance of active listening, and that, again, was one of the key take-home points that we really stressed with them, that when someone comes into your office to talk to you, you have to stop what you're doing. You have to make eye contact, and you have to make them feel that they are the most important person in the world, to be active listening. So one of the nurse managers says, the listening skills with the staff, when we asked her, what do you think was important? What have you implemented? What has been important in team building? She says, because you get so busy when the staff would come into the office, I try to multitask. So I've learned to stop and focus my attention to what that person is saying and trying to actually listen to what they are trying to communicate to me. Another one said, I thought it was helpful that every time I have to speak to somebody, I have to concentrate on not doing other things. I used to be able to talk and do things on my computer, so there was no eye contact. Now I am very conscious of not doing that and really giving my time to the person that is coming to talk to me. And being present. If the staff knows there's somebody there rounding with them, we build a sense of accountability. And then they also talked about those who weren't doing huddles. That was one of the tools that we talked about, and they started implementing huddles and at least began the process of engaging staff. Conflict management was another key area where we really worked hard with them in the workshops, and where I think that they describe anyway it making a difference in building teamwork and promoting better patient care. As one nurse manager said, I'm listening now and trying to hear what they're trying to tell me. Then I let them help to resolve the issue. So we are working on resolving that, and I just listen at first, and I don't jump to conclusions about what they want me to say or do. I have learned that this helps them to problem solve. And that was really what we tried to teach them, about how not to solve problems for people, how not to resolve the conflict, but how to create the milieu, ask the right questions, bring people together, and make them accountable and help them to resolve the conflict in a way that was acceptable to all. Teamwork. We really, again, as Suzanne pointed out, we focused on building teams because obviously that is a key responsibility of a leader, especially on a med-surg unit. So as one manager says, now we try to help each other, offer to help. Before, everyone just seemed to be working by themselves. So I think we've seen lately some team building. One person is done for the day, so offers to help the other person. And again, this just seems so basic, but managers have so many competing priorities and so many things on their plate that they just don't think about what they need to do, the leadership that they need to exert, the standards that they need to set to build teams. So the third output, or the next phase actually in this process, decision-making with staff, and really encouraging now at this point, once we have gone through enhanced communication and team building, now really helping that team to work to make some joint decisions. So as one nurse manager said, I learned in the workshops how communication is so big. Now I'm giving them a lot more information. It's going to help them make decisions on the unit, which really has worked. In the past, they didn't really have much input. So now with everything that I've learned and giving them more information and asking all the right questions, I'm really feeling that they are getting more involved. And obviously that was one of our goals. As another manager says, now we put our heads together and we talk about things, different ideas that people shared. They're talking about some fall prevention activities. That was a good idea that was shared and implemented on their unit. Another manager talked about how she engaged her team, and they came up with a solution for locks for the medication drawers and cabinets. So one of our staff had recommended we get these coded keys. So we actually looked at a vendor to see how much it cost, got a fair price, and now we're going to install them hopefully in the next few months. So they were able to engage their team, involve them in problem solving, and actually implemented team member ideas. And we were really thrilled to see that. So what are they saying about the link to all of this in patient safety from the nurse manager's perspective? One nurse manager said, I think with this coaching, I'm able to see our fall rates have been decreasing because staff are now taking ownership of the unit and they're rounding more frequently. They are in the rooms. They are decluttering rooms without me having to point things out to them. They are actually going into the room and taking care of tasks that need to be done. And she went on to describe how it's not only obviously the RNs, but the aides and the unlicensed personnel who are engaging and taking accountability for this care. And again, it seems so basic, like, I want to say, well, gee, weren't they doing that before? But unfortunately, not always. And it really took the nurse manager leadership to bring the team together to do this. Another nurse manager said, I think with our falls, we had a high fall rate. But once we started speaking about falls frequently at our huddles, I got some nurses involved in our falls committee to bring in that awareness and that education back to the staff nurses. So we've really been reducing our falls rate just by bringing education and awareness and talking about it at our huddles and rewarding team members that were doing a great job. And lastly, leading for safety. And the managers really who attended started to understand the difference between managing and leading. So this manager said, overall, I think that, which is the whole series of workshops, has improved patient safety on our floor, particularly with falls, with errors. I think that leadership sets a tone on the floor. Hopefully it's because of some of the things I learned from the course. Morally and ethically, I set a standard because this is the way I would do things, and hopefully they are following that. And another manager said, I think it was an eye-opener for me as far as the leadership portion, and she's talking about the workshops. Going from a manager to trying to be a leader, a more effective leader, is something that I really found to hit me in the area that I wanted to improve upon. I learned a great deal about leadership and conflict management and accountability. I handle things a little bit different now with the staff on accountability. Instead of doing everything, assisting them, I let them do some of the problem solving and ask them questions instead of just saying why, which was one of the skills that we worked on. Don't ask why you did something or why you didn't do something, but ask more probing questions of staff about what were they thinking, what did they hope to achieve to get them really engaged. So that was the qualitative findings. Now, what did the quantitative findings show? Well, in our surveys of the staff nurses on the 56 units across all units, we did find a significant correlations between staff nurses' perceptions of their managers' team-building skills and an inverse association with the team-building skills and conflict, which is what we were looking for, an inverse association between managers' team-building skills and their perceptions of a punitive culture, a positive association between managers' team-building skills and the nurses' perception of teamwork, and a relatively strong correlation between managers' team-building skills and their staff nurses' perception of a supportive work environment. Entering all of those factors into an equation, looking at predictors of medication safety practices by staff nurses on the unit, which was measured by a little instrument we developed in our last INQRI project. We found that all of these unit factors, conflict, perceptions of a punitive culture, teamwork, and a supportive practice environment, were predictive of medication safety practices of staff nurses in the expected direction. And so, again, these findings support, at least in part, sort of the qualitative descriptions of the managers, that these things are important and that these are skills that need to be developed. When we added managers' team-building skills to that regression equation, all of those other unit factors became non-significant, and it was the manager's team-building skills that was the final and the strongest predictor, if you will, of nurses' medication safety practices on the units. So again, it just points out the importance of the team-building skills of frontline nurse managers. Was there a difference between the control units and the intervention units on falls and medication errors? Sadly to say, no. We could not find any quantitative difference looking at the trends over the 6-month period post-workshops. And there may be many explanations for this. It could be, for example, that there just wasn't enough time. We didn't look at it long enough. That 6 months wasn't a long enough period. It could be that there was contamination and nurse managers were sharing skills. It could be patient factors. I mean, so many different factors. But we thought we'd try. We were hoping, to find some quantitative difference, but did not. What we did find was something unexpected, and it has to do with nurse manager workloads. And this was just anecdotal that I sort of stumbled over this. I was talking to one of the nurse manager attendees one morning at the beginning of the workshop, and he said to me, please forgive me if I look tired or I look sleepy. He said, I was up all night doing performance evaluations for my staff. And I said, oh my, how many performance evaluations did you do last night? He said, 60. And I said, oh, my, how many staff report to you directly? He said, 120. So that prompted me just to do a little quick and dirty survey of the nurse manager attendees to find out how many direct reports they had. Obviously, this project wasn't designed to look at this, but it was such an interesting thing to me. And again, it was my naivety, I suppose, that I didn't realize that the span of control is so large these days on med-surg units. But what we found was that frontline nurse managers have between 40 and 120 direct reports, staff that report directly to them. The average was 68, with a fairly large standard deviation of 24. 50% of our manager attendees had greater than 50 direct reports. Almost 20% of them had greater than 90 direct reports. Now, I cannot say quantitatively, scientifically, that this impacts their ability to be a good leader, that this impacts patient safety. But I do have to raise the question, is this wise? If you have 120 people reporting directly to you, how much engagement can you become involved in? How much conflict management? How well can you lead when you have that many direct reports? And I think that it points to really a gap in our scientific knowledge. What is the right number of direct reports for a frontline nurse manager? Quite frankly, I don't think that we have any type of quantitative guidelines for that is based on scientific inquiry. What we have been doing the last 10, 15 years is really focusing on the staff RNs and the RN to patient ratio, but we have not been focusing on the frontline nurse manager to staff ratio. And maybe that's the next area that we need to explore to truly advance patient safety. So at this point, Suzanne, if you could take maybe about 5 or 10 minutes to give us your impressions and your conclusions, and where should we go from here? Suzanne?
Thank you so much. I think that where Linda ended is really important to look at, because one of the things that we've learned from the aviation safety movement and from other high reliability industries is that workload management is critical to safety. And with that kind of span of responsibility and that kind of work, it's really difficult for nurse managers to lead as opposed to manage, because they can't engage in the kind of troubleshooting to find out where problems are. I think one of the most important things about team intelligence and where we have to move beyond is that it's not just enough to actively listen. One has to actively solicit. One has to not just have time for people coming to you with problems, but to going out and learning where the problems are and where the solutions are and promoting those. And I think that this issue of having too many people to supervise is rather like the parallel in management of the problem that nurses have, where they have too many patients to take care of. And it's very difficult just as it's very difficult for the nurse, the staff nurse whom the nurse manager is managing to emotionally and support and to find out what the patient needs to get better, which of course all has relevance to cost. It's very difficult for the nurse manager to find out where the glitches are, the safety glitches on the unit, if that manager has no time for that. So I think workload management is really key, and I think that that unexpected finding really helps to explain a lot of the other data that Linda Flynn has discovered in why people feel so unsupported. I think that what was very clear to me and to us as we looked at this project was that this was a really wonderful thing to do, but it really is just the tip of the iceberg, and also that in this kind of workshop needs real follow-up. The reason why other high reliability industries succeed in helping people to build teams and maintain teams so that they can prevent, manage, or contain errors is that the trainings are recurrent. And I think that the biggest problem for nurse managers, even those who are confronted with something as valuable as this project we feel was, is that this is really just a drop in the bucket, and behavior doesn't change through 5 workshops. And I think one of the things that I came away with was how important this is and how it needs to be recurrent for the people who were in it. We were very lucky to have a broad number of institutions involved in this. I think it would be great if there were next rounds to have more nurses from institutions because if you have two nurses from each institution isn't enough to have a critical mass to change that institution. So I think recurrent training is essential, and to bring more, to just do trainings and to do recurrent trainings because that's the way you make lessons stick and change behavior. I think another really important issue is taking advantage of for nurses who want to lead, taking advantage of the new focus on patient safety and interprofessional education and practice, which we see in North America and all over the world, and using that as leverage to move team building into institutions. You don't do interprofessional practice just by asserting it. You have to learn how to do it. And it was pretty clear that a lot of the managers in the program didn't necessarily have support to work intensively with physicians, and there was a lot of problems between different kinds of staff that really need to be addressed and that we need to learn more about. This was a very interesting, not only action promoting set of workshops, but also it helped us understand a lot of the problems. And some of those problems are between nursing staff and physicians, but also very many of those problems exist between nursing staff and techs and aides and LPNs, and that really needs to be addressed. I think this was a wonderful lesson in how very small-looking interventions can really change mindsets, and I just think it's very important for an experiment like this to be continued in a more serious way. I know I'm writing a book on teamwork. Bridget Reagan and I are working on a book on teamwork in healthcare, and I think these kinds of trainings need to be done really systematically throughout all the hospitals because we've just found very interesting evidence of how it can help in just 5 sessions. And imagine if this were something like this were systematically implemented throughout a hospital, or given more time and energy than we had. These are very positive results, and I just can't help feeling how much more positive an impact something like this could have if it had even more serious attention and resources.
Thank you, Suzanne. I think at this point we can open up the lines for discussion, questions, reactions. So, Heather?
That sounds great. Thank you so much. At this point, what we'll do is we'll take questions 2 ways. You can submit them through the Q&A feature or the chat feature on the computer. You can also indicate that you would like to ask your question on the phone. And Tricia, how will participants indicate that they would like to speak?
For the phone lines, you can press *1 and just make sure that your mute function is turned off.
Great. Thank you so much. In the meantime, though, we do have a few questions that came in on the chat feature, so I'll go ahead and read those to you, Linda and Suzanne. The first one was, do you recommend any books or resources to learn more about team intelligence?
Well, thank you for that, Linda, if I may. I have an essay in my new book, which is called First Do Less Harm, on team intelligence. I have team intelligence cards that I've had and that can be shared, that can be given out to help people, and there are several other books. There's a very excellent book by Scott Reeves and his colleagues. It's REEVES, on interprofessional teamwork for health and social care. J. Richard Hackman's books on teamwork are extraordinary, leading in teams. I really recommend his work. Amy Edmondson's articles on psychological safety are wonderful, and there's a wonderful book by Edgar Schein, called Helping, which is about teams. So there's a lot of stuff that one could read. I sort of coined the term team intelligence, and I describe it in First Do Less Harm, but there's really some wonderful stuff on teams. And I also think that teamwork should be integrated into real serious teamwork education should be integrated into the training of nurses and doctors and anyone else who works in healthcare, and it also should be integrated into the education of AD nurses in diploma schools, which have tended to be ignored in this interprofessional push.
Great, thank you. Our next question was, were your the huddles that you mentioned, interdisciplinary or limited to nursing members?
No, they were not necessarily limited to nursing members. Obviously, interdisciplinary is sort of the gold standard, and that's what we would all hope for. But on some units or in some institutions, that is not happening, or is problematic, or is more difficult. So basically, our philosophy was at least do your own team huddles if you can't bring in other disciplines. And if you start with that, then maybe the culture in your institution will start to change, or on your unit it will start to change, and you can then expand to interdisciplinary huddles.
Great. Linda, can you explain or define CRM again?
Oh, crew resource management. It's actually an airline industry term, and the airline industry really credits their training of all, not only the pilots, but the flight attendants and all staff associated in the airline industry. They have mandatory annual crew resource management training, and it is basically teamwork training. I mean, the key principles are communication, teamwork, situational awareness, being aware of what your team members are doing and what their challenges are, stepping in and helping them, having each other's back. Those are some of the key principles of crew resource management. And our workshops were organized loosely around those principles, but it was really great, having Pat Mendenhall, the pilot, and the CRM trainer, make those parallels of how CRM has helped improve airline safety, and how this kind of teamwork could also help improve healthcare safety.
Just for anybody who's interested in knowing a bit more about that, Patrick and I and a medical educator, Bonnie O'Connor, are coming out with a book in December called Beyond the Checklist: What Else Healthcare Can Learn from Aviation Safety and Teamwork.
Great, thank you. I had 3 questions that came in almost at the same time related to implementation. So I'm going to cluster them together, Linda and Suzanne.
Okay.
Maybe we can kind of find our way a little bit. Are there things that you would recommend for facilities to implement the nurse manager training who might not have external or grant funding? And are there tools available from your study that could be used for other either departments or nursing schools or et cetera?
Right. We use tools that already exist, like the leadership assessments, skill tools, and whatnot. And I could certainly, Heather, send you a list of what we used and where people can find them.
Great. That would be great.
Yeah.
Everyone, I'm going to put my email address up in the chat feature. So if those are tools that you're interested in receiving, when Linda sends them to me, I could forward them out to you.
I would certainly, recommend that people implement a series of workshops or training programs or whatever that include some of these, highlighted areas: transformational leadership, team building, conflict management. And I'm sure that there are local people in the area or at the local universities that might be expert in these areas that, probably for a reasonable fee would be willing to come and lead some of those sessions.
Great. I also had another question about what were your emotional intelligence findings?
Findings?
Yeah.
We had the managers, read the book, complete the questionnaires, and then come back and tell us what they found were their strengths and weaknesses. But it was not part of the evaluation. We did not collect any data on that area. It was more for their self-learning about themselves.
Let's see. This is a good question that I don't think we can answer. Will RWJ fund a project to revise this nurse leadership program for public health nurses? The last part of it clipped off. I think that's a great question. I don't know what other programs exist or what have you. I'm sure Linda is interested in finding that out as well. But I would advise anyone that's interested in learning more about RWJ's funding to take a look at their funding opportunities page on www.rwjf.org. You can sign up for funding alerts and find out what programs are going on, and I'll throw that up in the chat feature as well. I think there was one more, and then I'll turn it over to you, Tricia, for a second. Can you discuss some of the issues that arose during your study that folks might consider if they are trying to implement a similar program? Any lessons learned?
Okay, from the evaluation perspective, or from the workshop perspective?
The person didn't ask. I'm guessing from the workshop, just from what other questions came in, but I'm not sure.
Okay. Yes, we're challenged with some of the same issues that some of the audience is challenged with. Because we had funding, we were able to bring these fantastic experts from around the country to come and do these wonderful workshops. But that takes money, and and how do where do we go from here is really our biggest challenge. We attempted to address that by giving all the manager attendees two workbooks. One was their sort of working workbook with all the notes and exercises that from the workshops that they participated in, and the other we developed a train the trainer workbook, which was very scripted, which would help them share some of these skills with other nurse managers in their facilities. And we are hoping that will have that will be at least somewhat successful in sort of spreading the skill set. But as you all well know, some people are very good at teaching and leading in small groups and sharing information with others, and other individuals are not. So I'm sure some of these managers will be great trainers, and other of these managers will not be such great trainers. But it was our attempt to at least try to to generate ongoing. But that's our biggest challenge is how do we make this available to other settings, other hospitals, other nurse managers. From an evaluation perspective, the whole control and intervention unit thing was difficult. The managers who wanted to share what they were learning were sharing, regardless. They didn't care about the evaluation plan. So talk about contamination. It was pretty bad. I'm excited from an educational perspective that they were able to do that, but from an evaluation perspective, it was not helpful. So those were our challenges.
Great. Let's see. I think the last question that I have is do you know of anyone looking at the notion of minimum manager to staff ratios?
To my knowledge, no one is looking at that. I think, like I said, it's something that we absolutely need to look at. And I would recommend any nurse researchers and nurse administrators out there, other disciplines who want to look at this issue. I think it's ripe. I can't, like I said, I have no data to back it up, but just common sense and looking at other industries tells me that 120 direct reports for a frontline nurse manager is not good.
Right. I've got a couple of emails that people have sent to me requesting that I send the tools, so I will do that once Linda has sent them to me. But in the meantime, Tricia, do we have any questions on the line at your end?
No one has signaled at this time.
Okay. I want to make sure that I haven't missed any in the chat feature. This has been a wonderful conversation, and thank you all so much, not only for attending, but for submitting your questions. Thank you also, of course, to Linda and to Suzanne for joining us today and being a part of our webinar series. Just like all the other sessions that we've had up till this point, this session will be made available after the fact. In a couple of days, we'll have it up on our INQRI YouTube channel, which you'll be able to get to not only from YouTube, but also from our website, www.inqri.org. And like I said, that'll be up in a couple of days. So thank you again so much for all of you.
Thanks indeed.
Thank you.
Thank you for having us.
Yes.
All right. All right.
Take care, everyone.
Afternoon.